Good morning, Dr. Phil here. Today we'll be discussing on the arterial tourniquet. Introduction. A tourniquet is a device which is used to control the flow of blood to and or from an extremity. The word tourniquet itself derives from the French verb tourner, to turn, and was used by the 18th century French surgeon Louis Petit, describing the screw-like device he strapped to the thighs of patients undergoing leg amputations to reduce blood loss. Only pneumatic tourniquets should be used. Mechanical tourniquets can cause areas of unpredictably high pressure in the underlying tissues. A pneumatic arterial tourniquet system comprises of an inflatable cuff connected to a compressed gas supply and a pressure gauge which keeps cuff pressure at a preset value. Measurable and high pressures generated by these tourniquets allow controlled arterial compression and distal circulatory stasis. The limb can be exsanguinated by either arterial pressure and elevation, a pneumatic air exsanguinator, or via an S-March bandage, which is the most effective method. Regarding elevation, effective exsanguination can be achieved by arm or leg elevation for 5 minutes at 90 degrees without mechanical compression. Complications of tourniquet use are rare but can be catastrophic. The incidence of significant complications is low. One large Norwegian survey of more than 63,000 cases reported a rate of persistent complications of 0.04%. 50 neurological complications were reported with an incidence of 0.024%, of which 2 were permanent and the remainder resolved within 6 months. Local effects are the result of tissue ischemia distal to the inflated tourniquet and a combination of ischemia and compression of the tissues beneath it. Tissue compression predominantly affects nerve tissue, whereas muscle is more susceptible to ischemia. Widespread systemic effects of arterial tourniquets usually result from cuff inflation and deflation. Indications for the arterial tourniquet: to reduce blood loss post-trauma, to produce a bloodless field for extremity surgery, for example, joint replacements and the repair of tendons, nerves, and blood vessels. This can be very important in the case of microsurgical procedures to be able to visualize microanatomical structures. Use of tourniquets could decrease intraoperative blood loss. However, post-operative blood loss may increase due to hypothermia, hypoxia, and acidosis-induced coagulopathy caused by the tourniquet. Intravenous regional anesthesia or Beer's block. Beer's block consists of injecting local anesthetic solutions into the venous system of an upper or lower extremity that has been exsanguinated by compression or gravity and that has been isolated by means of a tourniquet from the central circulation. August Beer is credited with being the first physician to use this technique in 1908, and he used procaine 0.25% to 0.5%. Currently, prilocaine 1% is used in Europe, and lidocaine 0.5 to 1% is used in the United States. The technique has found its greatest acceptance for use for the upper extremity, as tourniquet problems and other safety issues seem to arise more frequently when IVRA is used on the lower extremity. The local anesthetic appears to work by 2 mechanisms: by direct action on the tissues in the exsanguinated limb and by action on the nerves running through these tissues. Indications for IVRA: for the upper extremity, fracture manipulation, surgery on the limb distal to the cuff, up to 60 minutes, complex regional pain syndromes, and treatment of hyperhidrosis, for anesthetizing the hand prior to injecting botulinum toxin A. For brief surgical interventions of the lower extremity, such as digital nerve repair and excision of a mass, note that anesthesia rapidly diminishes when the cuffs are deflated, therefore supplemental local anesthetic may be needed. Absolute contraindications includes patient refusal and history of local anesthetic allergy. Relative contraindications includes severe vascular disease, ischemia or crush injury, inability to locate peripheral veins, local skin infections, cellulitis, compound fractures, pre-existing vascular arteriovenous shunts, severe peripheral vascular disease, sickle cell disease, uncontrolled hypertension, obesity, and surgery lasting more than 1 hour. Relevant anatomy includes the location and distribution of veins of the hand, of the antecubital fossa, and of the foot and ankle region. Adverse effects of IVRA includes drug-related complications such as LA toxicity, methemoglobinemia, and poor quality blood, opioid side effects, neuromuscular blockade, and compartment syndrome. Equipment-related complications includes tourniquet pain, hypertension, equipment misuse or malfunction, nerve damage and arterial thrombosis. Other complications includes phantom limb sensation. Technique of the Beer's block. A proper anesthetic assessment should be conducted. The procedure should be explained to the patient and informed consent obtained. It is important to give the patient a good explanation of the technique, as initially the exsanguination process, tourniquet and ischemia can be uncomfortable or painful before the LA takes effect. Proper preparation. Anesthetic room or dedicated block room with full monitoring according to AAGBI standards. The block should be performed in an area with full resuscitation facilities. Ensure adequate trained assistance. Ensure adequate equipment and medications, as listed here. Patient. For simple procedures where there is no risk of needing to convert to GA, there is no need to fast. If there is potential need for sedation or GA, normal fasting precautions should be followed. The patient should lie in the dorsal recumbent position as long as the vein selected for placement is readily accessible. Regarding IV cannulae, insert an IV cannula in the non-operated limb for administration of essential drugs. A cannula is also inserted into a vein on the operative limb. For surgery on the elbow, the needle will be placed in the forearm or antecubital fossa. For procedures on the hand or forearm, a vein in the dorsum of the hand is best selected. Ideally, but not essentially, the IV cannulae should be placed distal to the operative area. For lower extremity procedures, a vein on the foot, ankle, or lower leg is chosen. Apply monitors and assess baseline vital signs. If the patient is in severe pain, IV analgesics may be administered, such as fentanyl boluses, to facilitate the exsanguination process. IV midazolam may be administered for anxiolysis. Benzodiazepines also suppress the convulsant response associated with LA toxicity. Place a double cuff pneumatic tourniquet system proximally on the operated limb. Exsanguinate the limb via either elevation, compression of the supplying artery, as much bandage or a combination depending on the nature of the injury and surgery. Inflate the distal cuff first to 100 mmHg above the systolic blood pressure. This tests the function of this cuff. Then inflate the proximal cuff to the same pressure. When both cuffs are shown to be effective, the distal cuff is deflated, then remove the as much bandage if present. LA is then injected slowly intravenously, avoiding high pressures that will exceed the tourniquet pressure. Volume for upper limb, usual volume is 40 ml, for a small arm 30 ml, for a large arm 50 to 60 ml. Choice of LA includes Prilocaine 0.5 to 1%, maximum dose is 6 mg per kg, or lidocaine 0.5%. Bupivacaine and ropivacaine are contraindicated. Additional distal pressure is advocated by some clinicians to limit the spread of LA to the area of surgery. When all LA is injected, the IV cannula is removed and pressure is placed over the cannula site. The distal cuff is inflated after 10 minutes or when the patient finds the tourniquet pressure is unbearable. The proximal cuff is then deflated. Deflating the tourniquet should not be done before 20 minutes have passed from injection of LA. The patient should then be monitored for signs of LA toxicity. IVRA for the lower extremity requires larger volumes of LA, about 100 ml, to completely fill the larger vascular compartments of the lower extremity. Useful LA adjuncts includes NSAIDs, opioids, and muscle relaxants. For further details, kindly refer to nysora.com. Other indications for the arterial tourniquet includes intravenous regional sympathectomy with drugs such as guanethidine. Guanethidine is an antihypertensive drug that acts at the sympathetic neuroeffector junction by inhibiting or interfering with the release and distribution of noradrenaline. It is rarely used for hypertension, but is sometimes useful for complex regional pain syndrome. The dose is 10 to 25 mg in 20 ml saline injected IV into the exsanguinated arm, and 30 to 40 mg in 40 ml for the lower extremity, and the tourniquet is then kept inflated for 10 to 20 minutes. Close cardiovascular observation is required, as hypotension may be delayed. A small amount of lidocaine is sometimes added. The procedure may be repeated, for example on alternate days for a number of weeks, often with long-lasting results. A guanethidine block is also used for sympathetic blockade with heparin anticoagulation to reduce the risk of thrombosis after inadvertent intraarterial injection of drugs. It is performed like a Bayes block. The dose is guanethidine 10 to 20 mg IV plus heparin 500 units in 25 to 40 ml of saline, and the cuff is left inflated for 20 minutes. The effects can last for several weeks. Guanethidine may cause diarrhea and postural hypotension. The arterial tourniquet is also used in the isolated forearm technique as a tool for researching anesthetic awareness. This is simple, ingenious, and arguably the most effective technique to assess depth of anesthesia, and is described originally by Turnstile in 1979. The anesthetist agrees with the patient, the hand signals that they will use to convey awareness, and arterial tourniquet isolates the arm from the drugs such as muscle relaxants which enter the systemic circulation. The patient may be unconscious when he or she fails to respond appropriately to the agreed commands. Around half of the patients who responded appropriately to the agreed commands have any later recall of having done so, as anesthetic agents may prevent memory formation at doses lower than those needed for loss of consciousness and immobility. Downsides of this technique: considerable degree of cooperation is necessary, and ischemic paralysis supervenes after 20 minutes of tourniquet inflation, and this prevents any further arm movements. The arterial tourniquet is also used in isolated limb perfusion with high-dose chemotherapy for patients with localized soft tissue cancers in specialist oncological centers. Contraindications for the arterial tourniquet includes absolute contraindication, patient refusal. Relative contraindications includes major trauma or crush injuries to the operated limb, localized infection or tumor, as the exsanguination process may disseminate the tumor or infection, peripheral vascular disease, particularly affecting the leg, use with caution in patients with poor cardiac reserve or a fixed output state, sickle cell disease, patients who are at high risk of venous thrombosis, and small tourniquets on fingers and toes. Mechanical pressure and local effects. Effects on the skin includes injury from as-much exsanguinators, chemical burns, and friction burns. Shearing stresses caused by a as-much bandage can injure the skin, as they can generate pressures as high as 1000 mmHg. As-much exsanguinators are more likely to cause nerve injury compared to pneumatic devices. Chemical burns are the most common form of skin injury and occur when alcohol-based solutions used for skin preparation sit beneath the tourniquet, which are then held against the skin under pressure. Friction burns can result from movement of poorly applied tourniquets. Mechanical pressure effects on the nerves includes nerve injury and tourniquet pain. Nerves under the cuff itself are vulnerable to nerve injury. A physiological conduction block develops between 15 and 45 minutes after inflation of a cuff around the arm to a suprasystolic pressure. The conduction block affects both motor and sensory modalities and is reversible after deflation of the cuff. The rate of development of this conduction block is the same with cuff pressures of 150 and 300 mmHg, and this suggests that ischemia rather than direct compression is the cause. Tourniquet paralysis. Direct mechanical compression of nerves is responsible for a second, longer-lasting nerve conduction block. Injury is secondary to both ischemia and to pressure. Direct mechanical compression effects are more likely at the edges of the cuff, as shearing forces are the highest here. There is a high differential pressure between compressed and non-compressed nerves at the edges of the cuff. The pressure gradient results in displacement of the nodes of Ranvier, stretching and degeneration of paranodal myelin, and impairment of nerve conduction, which may last for up to 6 months. Intraneural microvascular injury and edema results in axonal degeneration. Associations of nerve injury includes long tourniquet times, high mechanical pressure, and multiple injuries along a nerve. The radial nerve is the nerve most at risk in the upper limb, and the sciatic nerve is the nerve most at risk at the lower limb. Lower limb tourniquets are more likely to produce neurological complications than upper limb tourniquets. Kindly refer to the video Perioperative Nerve Injuries for further details. Tourniquet pain. Inflation of a tourniquet is followed by the development of a dull aching pain. In the awake patient, tourniquet pain is dull and poorly localized, and the intense discomfort intensifies with time. In both awake and anesthetized patients, it is associated with hypertension and tachycardia. Pain may persist even during dense neuraxial or deep general anesthesia. The mechanism is complex. High pressure prevents nerve conduction in fast A-delta pain fibers, while having less effects on the smaller non-myelinated, slow-conducting C fibers, which continue to transmit cutaneous impulses. Unmyelinated, slowly conducting C fibers are less affected by the compressive effects of tourniquet inflation compared to larger fibers. One theory suggests that tourniquet pain arises from selective transmission via cutaneous C fibers. Often the physiological changes are resistant to analgesic drugs and increased depth of anesthesia. Tourniquet pain can complicate spinal or epidural anesthesia, despite apparently adequate anesthesia of the sensory dermatome underlying the tourniquet. Smaller unmyelinated C fibers are more resistant to local anesthetic-induced conduction block compared to larger myelinated A fibers based on in vitro studies. LA concentration in cerebrospinal fluid decreases after intrathecal LA administration, and C fibers start to conduct impulses before the A fibers, and this results in dull tourniquet pain in the presence of an anesthetic, which when assessed by pinprick appears adequate. Potential treatments include small doses of ketamine, 0.25 mg per kg IV, before tourniquet inflation, increasing the density of central neuraxial blockade using adjuncts such as adrenaline, morphine or clonidine, preoperative gabapentin, and beta blockers. Mechanical pressure effects on muscles and vessels. Muscles directly beneath the cuff are subject to pressure effects and are more likely than nerves to be adversely affected by ischemia. Following inflation of the tourniquet, there is reduced PO2 and increased PCO2 within muscle cells. Energy stores reduces with time. Intracellular stores of ATP and creatine phosphate are exhausted after 2 and 3 hours respectively. Lactate concentration increases with the switch to anaerobic metabolism, with increasing PCO2, and intracellular acidosis develops. Microvascular damage and muscle fiber necrosis occur only after 2 hours of tourniquet ischemia. Reactive hyperemia results in increased blood flow to the muscles on deflation of the cuff, but into a circulation with increased vascular permeability. After tourniquet deflation, increased vascular permeability results in interstitial and intracellular edema, which frequently leads to the post-tourniquet syndrome. In the tourniquet syndrome, the patient presents with a swollen, pale, stiff limb with weakness but no paralysis, and this can last 1 to 6 weeks. Compartment syndrome may rarely occur, with post-ischemic swelling and edema, in combination with reperfusion hyperemia. Rhabdomyolysis may rarely occur, and most cases have been associated with unusually long ischemic times or high cuff inflation pressures. Thrombus formation may occur. Atheromatous vessels can be traumatized, particularly in the lower limb, and peripheral vascular disease increases the risk of thrombus formation. Arterial injury may occur, although it is rare. In one series, only 7 arterial injuries were reported in more than 5,000 knee arthroplasties, but 3 of these resulted in amputation. Acute vascular insufficiency is thought to occur when mechanical pressure from the tourniquet damages atheromatous vessels, causing plug rupture. Thus, many experts recommend avoiding the use of arterial tourniquets in patients with peripheral vascular disease. Systemic effects. Systemic effects during tourniquet inflation includes increased SVR, rapid autotransfusion, increased blood pressure, complications related to leakage, and intraoperative bleeding. Increased SVR. After limb exsanguination and tourniquet inflation, there is increased SVR and an effective increase in circulating blood volume due to rapid autotransfusion. Limb exsanguination is a form of rapid autotransfusion. A single tie tourniquet may divert up to 400 ml of blood into the circulation in an adult. Increase in blood volume increases CVP and systolic arterial pressure, which are usually transient. Sudden increase in blood volume is usually well tolerated, but it may threaten hemodynamic stability in patients with poor cardiac function or fixed cardiac output state, such as aortic or mitral stenosis. Cardiac failure and arrest have been reported after application of bilateral tie tourniquets, as application of bilateral tie tourniquet can increase the effective circulating blood volume by up to 15% or 750 ml in an adult. Increased blood pressure. Following the initial transient increase in arterial pressure, it is common to see a second gradual increase in arterial blood pressure. This is thought to accompany the development of tourniquet pain and develops after a variable period of time after inflation. The exact mechanism of this tourniquet-induced hypertension is not known. It has been suggested that it represents activation of the sympathetic nervous system in response to tourniquet pain. Plasma noradrenaline concentrations increases in parallel with arterial pressure during tourniquet inflation. In awake volunteers, the increasing arterial pressure runs parallel to the development of tourniquet pain. The rise in arterial pressure can be attenuated by addition of ketamine 0.25 mg per kg IV, which may also help with tourniquet pain. Clonidine attenuates sympathetic activity and, if given preoperatively, blunts the hypertensive response. Complications secondary to tourniquet leakage. During IVRA or chemotherapy, faulty or incorrectly applied cuffs can allow unintended access of drugs into the systemic circulation. This is particularly dangerous when large volumes of local anesthetic or cytotoxic chemotherapeutic agents are injected. Rapid injection through small syringes can generate higher pressures than larger syringes, and this may allow venous pressure to exceed cuff pressure and drug access into the systemic circulation. Causes of intraoperative bleeding in the context of tourniquet use includes incomplete exsanguination of the limb, poorly fitting or under-pressurized tourniquet cuff, and blood entering through the intramedullary vessels of long bones. Systemic effects during tourniquet deflation. Cardiovascular effects. During deflation of the cuff, there is reduction in SVR, MAP, and CVP as blood moves back into the now hyperemic circulation of the reperfusing limb. Post-ischemic reactive hyperemia occurs. There is transient increase in blood volume in the limb compared with baseline levels. Hypotension may last for 10 to 15 minutes. Metabolites from the ischemic limb are released into the systemic circulation, and this results in reperfusion syndrome, which will be discussed shortly. There is increased cardiac output after tourniquet deflation in response to the decrease in arterial pressure described above. Respiratory effects. There is a brief increase in fractional concentration of expired CO2 and peaks at around 1 minute as residual hypercarbic blood in the ischemic limb rejoins the systemic circulation. The FeCO2 can rise by as much as 18 mmHg but fall to baseline levels within a few minutes. These changes are more marked with lower limb tourniquets. The duration of the increase of FeCO2 depends on the ventilatory characteristics of the patient. In spontaneously breathing patients, minute ventilation increases rapidly, so FeCO2 returns to baseline values within 3 to 5 minutes. In patients receiving controlled ventilation, FeCO2 will remain raised up to more than 6 minutes unless there is an increase in minute ventilation. CNS effects. Transient increase in PaCO2 is associated with increased cerebral blood flow, cerebral blood volume, and intracranial pressure. Although this is usually insignificant, it can be important in trauma patients with closed head injuries. In patients with head injuries, increased cerebral blood flow can increase intracranial pressure and worsen the degree of secondary brain injury. Hyperventilation after tourniquet deflation can prevent deleterious increases in intracranial pressure by maintaining normal capnia. Reperfusion syndrome. Reperfusion of previously ischemic tissue is associated with an inflammatory response that is both local and systemic. Cellular effects of hypoxia is complex in detail. Failure of oxidative phosphorylation secondary to the depletion of oxygen diminishes the resynthesis of substances such as ATP and phosphocreatine. This reduces the function of ATP-dependent ionic pumps and results in accumulation of intracellular sodium, calcium, and water. Intracellular catabolism occurs, and there is production of molecules such as hypoxanthine from ATP degradation. When perfusion is restored, hypoxanthine reacts with molecular oxygen to form toxic oxygen radicals. Reactive oxygen radicals causes direct cell damage by lipid peroxidation. Ischemia primes the endothelium, which produces a number of pro-inflammatory species such as cytokines, endothelin, and thromboxane A2. Ischemia inhibits protective molecules, including nitric oxide synthase and prostacyclin. There is leukocyte activation. Polymorphonuclear leukocytes migrate from the intravascular space to the interstitium, and this is partly mediated by IL-8, which is released from hypoxic tissues. They then release a number of highly deleterious factors including reactive oxygen species, together with elastase and protease enzymes. This cascade of events, which is also amplified by complement activation, results in increased permeability of vascular endothelium, edema, thrombotic occlusion, and cell death. Systemic effects of the reperfusion syndrome includes systemic inflammatory response syndrome, multi-organ failure, and the no reflow phenomenon, which is caused by leukocyte adherence and platelet aggregation, whereby tissue blood flow remains reduced even after relief of the thrombotic or surgical occlusion. These leukocytes can also mediate a protective response that can enhance the barrier represented by the vascular endothelium, aka paradoxical effects. Metabolic changes. Accumulation of lactate and potassium proportional to the duration of ischemia results in transient plasma rises of lactate and potassium during reperfusion and mild metabolic acidosis that corrects within around 30 minutes. Peak increase of 0.3 millimole per liter of serum potassium occur within 3 minutes after deflation, and peak increase of 2 millimoles per liter of serum lactate occurs 3 minutes after deflation. Lactate and carbon dioxide returning to the systemic circulation from the ischemic limb reduces arterial pH. The limb venous pH is typically 7.0 after 2 hours of inflation time. Reperfusion of the ischemic limb and other hemodynamic changes associated with tourniquet deflation can cause brief increases in oxygen consumption and carbon dioxide production. The magnitude of these changes correlates with the duration of ischemia. Hematological effects. Tourniquet inflation during surgery is associated with a global hypercoagulable state. Increased platelet aggregation owing to tissue compression and catecholamine release is offset by enhanced systemic thrombolysis caused by the release of tissue plasminogen activator after tourniquet deflation. Catecholamines is released in response to pain from surgery and the tourniquet itself. After deflation of the tourniquet, there is a brief period of increased fibrinolytic activity. This increase is maximal at 15 minutes and returns to preoperative levels within 30 minutes of tourniquet deflation, but may nevertheless cause increased bleeding. The increased fibrinolysis is caused by the release of tissue plasminogen activator, which is thought to be produced by the vasa vasorum in the affected limb in response to the acidosis and hypoxemia associated with tourniquet application. Emboli formation during all lower limb surgery is common. Accumulated microemboli particles are released into the systemic circulation during tourniquet deflation. Subclinical cerebral embolisms are detected in 60% of cases, and subclinical pulmonary embolisms in 100% of cases after tourniquet deflation. Severe or even fatal pulmonary embolisms have been described. Tumor cells and septic particles can be released into the systemic circulation during tourniquet deflation as well, potentially causing metastatic spread of cancer, distant infections, and sepsis. There is 5 times increase in risk of large venous thrombosis in patients undergoing total knee replacement in whom a tourniquet is used. Temperature changes. Heat transfer from the core to the exsanguinated area is negligible, so central temperature can rise. The magnitude of this increase is small, about 0.5 degrees Celsius after 2 hours of tourniquet inflation. Following cuff deflation, redistributed blood loses heat to the cool limb, which quickly becomes hyperemic. Transient temperature falls of up to 0.7 degrees Celsius have been reported. Pharmacokinetic implications. Drugs such as muscle relaxants, opioids, and antibiotics cannot reach the operated limb from the moment of tourniquet inflation. Drugs that are stored in the operated limb remains mostly undegraded due to hypoxia and hypothermia. When the tourniquet is deflated, drugs trapped in the limb are released into the systemic circulation, potentially causing various effects depending on the type of drug, such as transient deepening of anesthesia and respiratory depression. Safe practice. All equipment must be well maintained. Prophylactic antibiotics used to prevent post-surgery infections should be administered early such that the peak level occurs just prior to tourniquet inflation. For cephalosporins, this level is reached 20 minutes after IV injection. Wrinkle-free padding should be placed between the skin and the tourniquet cuff to reduce skin damage due to shearing stresses. A self-adhesive plastic drape should be used to separate the tourniquet from the surgical field before skin preparation to avoid chemical burns of the skin beneath the tourniquet. A tourniquet cuff should not be moved once it has been inflated to avoid having shearing forces damage underlying tissues. Occlusion pressures and tourniquet inflation time should be minimized as much as possible. No strict guidelines exist, in part because there is no general consensus, but also because each patient is different and what is safe for one limb is not necessarily safe for another. Ensure a low pressure per unit area exerted by the tourniquet cuff. Gauge pressure can be misleading. High pressure per unit area occurs in a narrow cuff and in a large limb where the pressure is greatest at its widest point. The cuff shape should be conical, as this exerts pressure more evenly around the limb. The cuff size must be of correct size. The American Heart Association concluded that if a sphygmomanometer cuff has a width of 20% greater than the diameter of the upper arm, or 40% of the circumference of the thigh, to a maximum of 20 cm, then the pressure in the underlying central artery will be equal to that in the cuff. Modern silicone tourniquet cuffs tend to be smaller than this, measuring 90 mm in width, bladder 70 mm for the arm, and 105 mm, for the leg, bladder 75 mm. The cuff length should exceed the circumference of the extremity by 7 to 15 cm. Site of application of the cuff. The upper arm and thigh have sufficient muscle bulk to distribute the cuff pressure evenly and are the recommended sites. The cuff should be positioned at the point of maximum circumference of the limb. The tissues immediately underlying the cuff should be protected by cotton wool. This is not necessary with correctly applied modern silicone cuffs. A cuff tourniquet may be used by some surgeons for short operations, less than 1 hour, in fit patients. Minimize inflation pressure. In routine practice, the tourniquet is usually inflated around 100 to 150 mmHg above the systolic pressure, with the higher pressures reserved for the lower limb. Inflation pressure is typically based on the unsedated patient's blood pressure, measured in the ward preoperatively. For the upper limb, the inflation pressure is systolic BP plus 50 mmHg. In a normotensive patient, a pressure of 200 mmHg should be ideal for the upper limb. For the lower limb, the inflation pressure is twice the systolic BP. Higher pressure is needed because there is often not enough room above the operating site for a fully sized cuff. In a normotensive patient, a pressure of 250 mmHg should be ideal for the lower limb. Inflating cuffs to a fixed pressure have been criticized because it takes no account for the patient's usual arterial blood pressure. Younger age is an independent predictor of neurological injury after prolonged tourniquet times. It is hypothesized that this was due to younger patients having lower systolic pressures, meaning there is a higher difference between tourniquet inflation pressure and arterial pressure, leading to excessive compression. The use of lower inflation pressures may minimize complications following the use of tourniquets and speed up post-op recovery. Inflation pressure needs to be a little higher than that needed to occlude arterial flow. Thus, some have recommended using Doppler probes to detect the loss of peripheral flow before inflation to 40 to 80 mmHg above this level. The Association of Perioperative Registered Nurses in the USA recommends inflating tourniquets to pressures based on the limb occlusion pressure, LOP. This value is determined by gradually increasing the pressure in the tourniquet while assessing distal blood flow with a Doppler probe held over a distal artery. The LOP is the pressure in the cuff at which arterial pulse disappears. The LOP is usually higher than systolic pressure because the pressure from the tourniquet, which is transmitted to deep underlying soft tissue, is frequently less than that in the tourniquet itself. The percentage of transmitted tourniquet pressure varies inversely with limb circumference. Hence, the practice of using higher pressures in the thigh than on the upper arm. AORN guidelines recommend that the tourniquet is inflated intraoperatively to a pressure higher than the LOP. A safety margin is added to cover for intraoperative fluctuations in arterial pressure. If the LOP is less than 130 mmHg, the inflation pressure is 40 mmHg plus LOP. If the LOP is 131 to 190 mmHg, the inflation pressure is 60 mmHg plus LOP. If the LOP is more than 190 mmHg, the inflation pressure is 80 mmHg plus LOP. Duration of tourniquet inflation. A safe limit has not been established. Limits for inflation pressures and times should be tailored to individual patients. The minimum time possible should be the aim. Notify the surgeon at 1 hour and remove as soon as possible after that. If the operation is difficult, the time can be extended to 1.5 hours. Most recommendations in literature suggest a period of 1.5 to 2 hours in a healthy adult, which corresponds to the point at which muscle ATP stores are depleted. A 2-hour tourniquet time is a commonly recommended maximum to limit direct pressure effects and potential damage to distal tissues owing to prolonged ATP depletion and progressive tissue acidosis. Safe inflation time will be determined by the patient's age, physical health, and integrity of the vascular supply to the limb. Risk of Pressure effects are higher in the elderly, those with peripheral vascular disease, and if the limb is injured. A 2-hour tourniquet time will not be safe for all patients. Pulmonary embolisms can occur following tourniquet release, and when monitored using TOE, the rate was higher with increased tourniquet time. Although ischemia has typically been associated with muscular rather than neurological injury, there is approximately 3-fold increase in the risk of neurological complications with each 30-minute increase in tourniquet time. Periodic deflation and reinflation. If the duration of surgery exceeds the maximum safe inflation time, the tourniquet should be deflated for a short period. This allows metabolic waste products to be removed and oxygenated blood to perfuse the limb. It is generally considered that the tourniquet should be left deflated for 10 to 15 minutes before reinflation, and this seems to correspond to restoration of muscle ATP levels. It is important to re-exsanguinate the limb before inflating the cuff again after reperfusion. Tourniquets must be protected from contamination to avoid disease transmission. Novel therapeutic approaches include pre-tourniquet cooling of the limb, ischemic preconditioning, ischemic postconditioning, the use of antioxidants, and the use of milrinone. In the minutes and hours following deflation, it is of primary importance to regularly monitor the vascular and neurological status of the patient's limb in order to detect and treat potential complications as soon as possible. These are my references. Thank you.